We are live.
Good evening, everybody. I welcome you all to yet another iFocus online session. Currently, we are running in 494 episode. Today, we have Dr. Ritica Mukherji, ma'am, Associate Consultant at Center for Sight Eye Hospital, New Delhi, to teach us about topography guided custom ablation. Welcome, ma'am. We have Dr. Komal Saluja, ma'am, to moderate today's class after finishing her MS from VMMC and Safdarjung Hospital, where she got her gold medal. In Guru Gobind Singh University, New Delhi. She finished a senior residency from the same, after which she did a DNB and FICO. Currently, ma'am is an associate consultant at Center for Sight Eye Hospital, New Delhi. She has done her advanced PG diploma in clinical research and medical writing from James Lin Institute, Switzerland. She's a trained and certified cataract and refractive surgeon, actively involved in training DNB and fellow students, a wonderful mentor. She has delivered multiple presentations and has numerous publications to her name in both national and international journals, and has won multiple awards for best case presentations and ophthalmic quiz competitions. Welcome, ma'am, and over to you for the introduction of our chairperson, Dr. Pratik Tiotia, sir, and our speaker for today's, that is Dr. Ritika Mukherji, ma'am.
Thank you, Kritika. Good evening, everyone. It is my honor to introduce our session's chairperson, Dr. Pratik Tiotia, sir, who is widely recognized as an excellent cornea and refractive surgeon, and he has made significant contributions in the field of refractive surgery with years of academic experience. Welcome, sir. Sir has done his MBBS from PDM Medical College, Amravati University, and has completed his MS from Gandhi Medical College, Bhopal. He also holds FICO UK, FRCS from Glasgow, and fellowship from LBPI Hyderabad. Currently, he is working at Center for Sight, New Delhi, as a consultant in cornea, cataract, and refractive surgery. Previously, he was the director of CL Gupta Eye Bank, Moradabad, and was working there as a consultant in cornea, cataract, and refractive surgery. Sir specializes in phacoemulsification, LASIK, PRK, ICL, penetrating keratoplasties, lamellar keratoplasties, DMAC, and DALK, and has been a recipient of various prizes in quizzes, paper, and poster presentations in numerous conferences. He has been invited to various ophthalmic meetings, both national and international, for lectures and presentations. We are delighted to have you chair this session, sir. Welcome.
Thank you, Komal.
Now I have the pleasure of introducing our speaker, Dr. Ritica Mukherji, who is a young and dynamic refractive surgeon with excellent clinical acumen. She has done her MBBS from Rohilkhand University, Uttar Pradesh, and MS Ophthalmology from JN Medical College, Wardha, Maharashtra. She has completed her fellowship in cataract and refractive surgery from Narayan Nethralaya, Bangalore. Currently, she is an associate consultant at Center for Sight Eye Hospital. She is a ratified member of All India Ophthalmological Society and Delhi Ophthalmological Society, and she has published various articles in national and international journals. She has many awards to her name, including Best Poster at International Cross-Linking Meet at Zurich, Switzerland, and Best Poster at ESCRS 2023. She's also received Siva Hadia Award for Best Paper in Refractive Surgery in AIOC 2023, Best Paper in Innovation and Refractive Surgery in IRC 2023, and Best Paper in Free Paper Session at DOSCON 2024. Today, she'll be talking about topo-guided custom ablation treatment, TCAT.
Thank you, ma'am, for the introduction. I'll just share my slides. Okay, so I'll be talking about topography guided custom ablation treatment, or TCAT, in patients with keratoconus. Just a second. One second. Yeah. So these are the main headings under which we'll be discussing this. We'll talk about the advantage of a laser-based cross-linking for a patient with keratoconus, the criteria, the inclusion and exclusion criteria for TCAT, the types of TCAT, how it works. We'll briefly touch upon the Athens protocol, which was the first laser-based cross-linking protocol which was introduced. We'll discuss planning on 3 common platforms used for TCAT, and briefly touch upon the cross-linking protocols, use of mitomycin C, and the complications that we see with this. So whenever we talk about a non-progressive keratoconus, we can offer them visual rehabilitation in the form of spectacles, contact lens, and even intracorneal ring segments, which tend to regularize the cornea and improve the visual acuity of the patient. But when we're talking about a progressive keratoconus, we need to halt the progression as well as improve the quality of vision for these patients. So that is achieved either by manual cross-linking, or we can combine the cross-linking procedures with certain keratorefractive procedures such as PRK or again intracorneal ring segments in order to improve the visual quality of the patient. Keratoplasty is usually reserved for advanced keratoconus. So why do we need a laser-based cross-linking? Whenever we do a manual cross-linking, we do not regularize the cornea. We are simply treating the disease in order to stop the progression. As a result, because of the irregular cornea, there is poor contact lens fitting, improper spectacle acceptance. We are also not treating the higher order aberrations, especially the coma, which is prevalent in these patients, giving them suboptimal visual quality. With a topo-guided treatment, we can regularize the corneal surface, improve the contact lens fitting or the spectacle acceptance. And since we are also treating certain higher order aberrations, in general, there is an improved visual quality. So coming to when to do a TCAT, we have an article which tells us that we are reserving the topo-guided cross-linking for corneas which have a minimum thickness of more than 450 microns. And if the thickness is less than 450 microns, we prefer an intracorneal ring segment to regularize the cornea and go for a manual cross-linking. In any case, we need the thickness to be at least more than 400. The reason for this is once we remove the epithelium, we want the minimum thickness to at least be 400 so we can do a safe cross-linking. So we are targeting corneas which have grade 1 to 2 keratoconus, have a thickness of say around 450 or more. And pachymetry after ablation, which is equivalent or equal to 400 microns. These patients are usually unhappy with glasses or contact lenses or have a poor contact lens fitting because of a very steep cornea or a decentered cone. Of course, we would prefer central cones, and any active allergies or inflammations need to be treated prior to surgery, because since we're doing a laser-based procedures, patients who have prior inflammation are more likely to develop a haze or a scar. So that is why it needs to be treated first. Patients who are contraindicated to undergo a TCAT CXL, basically those who have central corneal scarring, they are not suitable candidates. Those who have a history of herpes simplex keratitis because they're at a greater risk of reactivation. And also those who have a dioptric difference across the cornea of more than 10 microns. This is not an absolute contraindication. It is just that in order to regularize the cornea, we will require removal of too much tissue, and this could lead to corneal haze, scarring, or regression, which is why it is a relative contraindication. Now, there are multiple names given to the same thing. We have multiple protocols which describe a combined cross-linking with a keratorefractive surgeries. So the names might be confusing, but the ultimate goal of all these procedures that I've listed here is that we need to stabilize the cornea. We need to stop the keratoconus from progressing, which is achieved with the help of cross-linking. Then we need to provide structural stability. So in some cases, we can do it with an intracorneal ring segment. And in other cases, we are trying to give them visual rehabilitation. So we can do a topo-guided PRK for these patients, or we can do a PTK, which removes less amount of stroma. So in a topo-guided PRK, earlier they were removing a lot of tissue. For approximately 80 microns was what was described in the original Athens protocol, along with a high fluence cross-linking. In the Cretan protocol, they brought it down to a trans-epithelial PTK with cross-linking. That is, they removed around 50 to 20 microns of stroma alone. This is usually not sufficient to correct higher order aberrations, but we can still achieve a little bit of corneal regularization. Again, Cretan plus protocol involved epithelial removal using a transepithelial PTK, followed by a PRK cross-linking. So there are different names, but ideally what we are trying to do is a PRK or a PTK and then follow it up with a cross-linking. We won't be discussing all of these. We'll discuss in brief about Athens and maybe Trek in the end. Now, how does a TCAT work? First of all, you should know that this is not a procedure to correct the refractive error. We cannot tell our patients that we are going to remove your spectacles because that is not the case. TCAT is a procedure of limited ablation of cornea using an excimer laser, and the aim is to regularize the cornea to improve the quality of vision, spectacle acceptance, and contact lens fit. So we may be correcting a partial refractive error, but we are never going to remove the entire refractive error. So what essentially happens is in this sort of a treatment, there is some flattening of the cone apex along with flattening of a broader arcuate area away from the cone. So because we are flattening a little bit of the periphery and flattening the cone, there is a central area of steepening which is adjacent to the cone, effectively normalizing the cornea because it is usually prolate in shape. So that is the shape that we are trying to achieve by this ablation pattern. We want to flatten the apex and create a slight zone of steepening just adjacent to it so that the prolate shape is maintained. So Athens protocol was the first to be described by John Canelopoulos and Perry S. Binder. They proposed a two-step procedure for cross-linking where they performed the cross-linking first, and after a year interval, they performed a PRK. The disadvantage of this is that we do not know the effect of PRK on a previously cross-linked cornea. Also, we have cross-linked the anterior stroma, and now when we are doing a PRK, we are essentially removing this cross-linked or the stable part of the cornea. Thirdly, with a sequential approach, what happens is after a year, the cornea gets repopulated with keratocytes. And so once we do a PRK on that, there is a higher rate of a post-operative haze formation. In a simultaneous procedure, we are already removing the keratocytes, so there is less chance of haze formation. So after this was introduced in 2009, again, Canelopoulos and Kaimonis described a patient with pellucid marginal degeneration in which they noticed significant improvement in uncorrected and best corrected visual acuity as well as the keratometric values after they performed a simultaneous topo-guided PRK with CXL. So they did a PRK and then followed it up with a cross-linking. After this, they also reported a series of keratoconus patients who underwent the same procedure and showed significant improvement in both the spherical equivalent defocus, UCVA, BCVA, as well as the keratometric values. In 2019, they published a 10-year follow-up of these patients, and they evaluated the same parameters which they had done initially, and they showed that there was a significant improvement in the parameter studies, or they remained stable throughout the 10-year follow-up. They also noted that none of the patients showed topographic or clinical signs of keratoconus progression during this long follow-up period. However, they noted that there was a posterior linear stromal haze in the central treated area, which was detectable on slit lamp, but over the course of the follow-up, it disappeared. It gradually moved up and disappeared. So this is what the Athens protocol involved. They kept an optical zone of 5.5 millimeters effective with a transition zone of 1 to 2 millimeters. They made sure that the maximum stromal ablation depth was not beyond 50 microns. Epithelium was initially removed by an alcohol-based technique, but later they started doing a PTK with a depth of 50 microns in order to remove the epithelium. Image acquisition was done on the Wavelight Pentacam oculizer and later on the Topolizer. Planning was, of course, on the WaveNet station, and the excimer laser used was Allegretto Wave Q400 Hz and later the Wavelight EX500. They did use MMC in their protocol for 0.02% for around 20 seconds, which was done prior to the cross-linking. And they did the conventional cross-linking for 30 minutes. So step 1 was removal of the epithelium. Step 2 was the topo-guided partial PRK, followed by the MMC application for 30 seconds, followed by the conventional cross-linking. So going forward on this, we'll discuss how we can plan the TCAT on the Alcon platform in this day and age. Now, we need to understand what are the treatment modes that this excimer laser offers us. There are 3 main modes: the wavefront optimized, wavefront guided, and the topography guided mode. For keratoconus patients, we prefer the wavefront guided or the topography guided mode. because wavefront optimize, it maintains the aspheric profile. But in our case, these keratoconus patients don't have an aspheric profile to begin with, and they have more higher order aberrations, whereas a WFO treatment will only treat the refractive error or the lower order aberrations. So what we prefer for these patients of keratoconus are either a wavefront guided or a topography guided treatment. The difference between the two is that wavefront guided considers the aberrations of the entire eye, starting right from the anterior part of the cornea to the posterior surface of the cornea to the lens and behind. So keratoconus affects both anterior and posterior part of the cornea. So chances are that it is more likely to pick up the very fine irregularities in the corneal surface, and that is why it is tissue saving, because it is discarding all the aberrations coming from behind the cornea. So usually these are more tissue saving treatments for keratoconus, whereas topography guided treatment, they treat more irregular surfaces or irregular corneas. So they are good for very steep corneas, very decentered cones, because they aim to correct the higher order aberration based on the patient's irregular topographic profile. However, both can be used. So we look at a case example. We have a 26-year-old female who wants to plan a pregnancy. She has ghosting, shadowing, and this is a refractive error. So we can see it's around a grade 2 keratoconus. Now, the first thing that we need to do is export good quality scans. How do we know it is a good quality scan? We can see that the pupil registration is in green. We want similar looking scans. So not just similar looking, we will see the K1, K2 values as well as the Q values. They shouldn't be more than 2 or 3 dioptric difference. If there is a data gap, or if the pupil registration is absent, or if there is a lot of difference between the values, we don't consider those scans. Usually 4 to 6 good scans is all we need to export. After we have exported, we will select the topography guided treatment for that eye. There is that when we click on that, we will get something called the fitting queue on the planning page. These are the scans which we've exported, and what we get is a fitting queue. So now usually if we have a keratoconus with a central cone, that is more than 50% of that cone lies in the central 3 mm zone on the posterior elevation map of the pentacam, they will usually have a high negative value or a high myopic refractive error. They are more hyperprolate. Basically, it is going towards a higher myopic correction. So in such eyes, if we treat a zero error, if we don't do any refractive correction, it will perform a topo guided ablation, but there will be very small change in refraction, and we will not achieve the desired outcome, because we want that there should be a little bit of refractive correction. We want that there is a arcuate ablation on top. We want that the cone is flattened. But if there is a central cone and we keep the Q value as 0, that will not happen. So in this case, we have the option of manually selecting the Q, making it less negative, or we can also apply a refractive correction, which we will discuss later. So this will help us get the shape that we want. So for example, in this, we are first going to check the 0 rule. So we need to check the ablation by applying the 0 rule. What that means is, we will first enter a 0 refraction, and we will check if the machine is ablating any part of the tissue. Usually in patients with keratoconus, even if we don't correct any refraction, the machine does give us an ablation pattern like we discussed earlier. It will flatten some of the apex. It will give us an arcuate correction with a central steepening. This is the kind of correction we want. So you can see, even if we don't treat any refraction, we are still getting a profile. The wavelight allows us to see the Zernike. Basically, we can see C7 here, which is the coma. We can see that it is around -1, and that is the higher order aberration which is contributing to the ghosting which this patient has. So what we want is a maximum ablation of say 40 to 50 microns. Now here we can see the higher order aberrations, but we cannot manipulate them. This is necessary because we will discuss later about the Schwind platform, where we can manipulate the higher order aberrations. In this machine, you can see them, but you cannot manipulate them. Now, the second step here is we've added the refraction of this patient. The patient was accepting a -3, but we have started with half the cylinder to see how much ablation we are getting. So this is where we can see the maximum and the central stromal ablation. This is after the epithelium has been removed manually in this case. We can also do a PTK to remove the epithelium initially. So now the epi of maximum stromal ablation is turning out to be 40, even though we have just corrected half the cylinder. And the central ablation is turning out to be around 24.3. Now we don't want to exceed 40, so we will stop here. If, however, in this case, we had maybe say 26 microns, we could still play around with around 20 more microns, so 1 or 2 diopters. So either we can add a little bit more to the cylinder. Our aim is to correct at least 70 to 75% of the patient's cylindrical acceptance. And then if left over, we will consider the difference between the central and the maximum stromal ablation. Why? Because central minus the maximal stromal ablation gives us how much myopia we are inducing as a result of our treatment. So that is the correction that we can add to the sphere if we are not exceeding 40 microns. In this case, we are reaching 40 microns, so we will not correct any sphere. We will only correct half the cylinder. So this is the pre-op and post-op scan of the same patient. We can see that there is significant flattening and there is a slightly steeper area adjacent to the cone. And we can see that the refractive error of the patient has reduced quite significantly. So how do we know that it is working? If you look at the Zernike on the pentacam, this is the pre-op vertical coma. We can see it was initially -1. Again, this is what we saw on the Zernike map, which we saw on the planning treatment. So the Zernike aberrations are available on the machine, but we cannot manipulate them. However, after treatment, we can see that it has come down to almost half. These are other examples of a corneal cross-linking done on the wavelight platform. You can see that there is flattening and a central steepening. Again, there is flattening on the away from the apex of the cone. Here we can see that the shape is not changed too much, but definitely there is flattening. It has gone from 47.5 to 45.6. And this itself is improving the patient's refractive error. So these are a few studies done studying TCAT along with cross-linking on the wavelight platform. Most of them have kept an optical zone of 5.5 to 6, and some of them have even reduced it further in case they had a central cone. A transition zone of 1 to 2 millimeters was kept. All of these studies had a maximum stromal ablation depth between 40 to 50 microns. This is in contrast to the Athens protocol where they did go up to 50 to 80 in some cases, but the mean was 50 microns. The epithelium removal was done either by mechanical debridement or an alcohol-based technique up to 8 to 9 mm zone. The image acquisition was again same as Athens protocol, same planning software and the excimer used. In these studies, MMC was not used and the cross-linking protocol used was the accelerated cross-linking protocol at 9 milliwatts per centimeter square for 10 minutes. A brief summary of these studies, all of them showed an improvement in the uncorrected visual acuity as well as the best corrected visual acuity and a reduction in the higher order aberrations. So the second study actually had a control group where some patients underwent the TGPRK with cross-linking, whereas there was another group where they only underwent a manual cross-linking. And they found that the reduction in higher order aberrations was significantly higher in those treated with the TCAT along with the cross-linking. Kmax was also found to be reduced in all these studies, and nobody required cross-linking in the second study. In the 10-year outcomes of the TCAT with CXL on the wavelight platform, 2 out of 600 eyes did progress and required a repeat cross-linking, which was done by the conventional technique. Similarly, we'll study how we can plan a TCAT on the Zeiss platform. Now, to plan it on Zeiss, we have the Atlas 9000 topographer, which gives us data on the curvature, elevation, as well as aberrations. The planning software, like we had WaveNet for Alcon, here we have the CRS Master, which is integrated with either the MEL 80 or the MEL 90 excimer laser. So it uses a flex sequence system, which provides either 250 Hertz or 500 Hertz operation. For the TCAT process, we will use the 250 Hertz planning. And the time taken for this is 1.3 seconds for every 1 diopter of ablation. Now for a TCAT in the CRS master, there are two main protocols available. One is the topography and one is topography smooth. So topography is similar to the PTK mode. There is regularization of cornea with correction of some, this is like the TCAT mode or the topography guided mode. There is regularization of cornea with correction of some refractive error. And topography smooth is like the PTK mode, where we are only removing, say, maybe 15 to 20 microns of the stroma. There, it is simply a regularization of the cornea, and we cannot treat any refraction in this mode. So this we reserve for thin corneas or say maybe recorrection surgeries where the refraction is treated at a later date. So we'll just see the planning station. This is the CRS planning station. Here we can enter the patient's refraction. And this is where we can change the optical zone. We can enter the thinnest pachymetry and then press on calculate. So it gives us basically the ablation depth as well as the RST. Now it also gives us something called the Z shift or the Z clip. These are two modalities which help us to reduce the ablation depth further, especially in keratoconic eyes, so that we can save more tissue. Now, how does this work? Basically, we want to reduce this ablation depth, which is the distance from the surface to the best fit sphere. Now, what happens in Z shift is it automatically shifts the best fit sphere. So it gives us a modified best fit sphere. What happens is in an irregular or a keratoconus cornea, if we move up or we modify the best fit sphere, the number of bumps that we have reduces. So in this way, we achieve a regularization. In Z clip, it ablates or clips only the steepest part of the irregularity. So based on the topography, it calculates which is the steepest points and it clips those points. It does not change the best fit sphere. So how can we use this in a patient? We'll just take an example of this patient with a BCV of -1 diopter sphere and -3 cylinder. And this is the Atlas scan for this patient. Now, if we choose the topo smooth, which is like the PTK mode, we can see that we are not adding any refraction. Now, when we calculate for this patient, we see that the ablation depth is very high. If we apply the Z clip or the Z shift or both, you can apply both as well, we see that it automatically reduces the ablation depth because A, it has modified the best fit sphere and it has also clipped the maximum irregularities that it can see. So this helps save some tissue. Again, if we plan the same patient in the topography mode and we add the refraction here, we can see we've added the manifest refraction. So here again, we've started with less than half of the cylinder and we've added a very small spherical correction. But again, the ablation depth is very high. So again, when we apply the Z clip or the Z shift, we can see that it has come down to 43. So if it is under 45, we can correct it. So again, in this, we have corrected a partial refractive error and we have made sure that we don't ablate more than 50 microns of stroma. That is the takeaway from this. And we have used the Z clip or the Z shift mode on the CRS master to do this. This is the outcome of the same patient. Again, we can see that there is a steepening just adjacent to the cone and again flattening. This is the kind of profile we want for our patients whenever we are planning a TCAT. And again, the acceptance of the patient has also improved in terms of the cylinder. So I could not really find any studies where the TCAT was done along with cross-linking on the CRS platform. I did find one study where they performed a PRK for keratoconus patients. This is just for the sake of completion. It is not a very good study because we can see that they did not perform cross-linking, even though in the study they've mentioned that the patients had keratoconus grades 1 to 3. And even though they did report an improvement in the UCVA, BCVA, and a flattening, I think that is because they've corrected the entire refraction, which is why their maximum stromal ablation depth went up till 80, which we do not prefer at all. But yes, they have also used an alcohol debridement technique and they've used the CRS master with the MEL 80 platform. They used MMC because they probably planned it as a PRK and not as a TCAT with cross-linking. So that is the limitation of the study. They've not performed cross-linking. However, with this set of patients, that is something which could have been done. We can perform a cross-linking and then follow it. We can perform a PRK and then follow it up with a cross-linking. A minimal PRK correcting partial refractive error like we just saw. Also in this study, they did not include the patients who had to undergo corneal transplantation later because of progression. So, which is why they were able to say that 19 eyes did not show progression. But yes, 9 eyes did show progression and 5 of them had to undergo corneal transplantation. Coming to the Schwind platform, this I feel is very user friendly in order to treat keratoconus using TCAT. It mainly comes with two machines, basically the Schwind Cirrus, which is your Placido with Scheimpflug corneal topographer, and the Schwind Osiris T. This is again Scheimpflug topographer, but it also has a pyramidal aberrometer. So this is why we can use this to plan a wavefront guided treatment, which they call the ocular wavefront guided treatment on this machine. So the Schwind Cirrus can be used to perform a topography guided or a corneal wavefront CW treatment. And the Schwind Osiris T, if the scans are taken on that, it can be used to plan a wavefront guided treatment. I'll discuss both side by side. The software used in this case is the OrCam software for planning the TCAT. But if we are planning a trek, we need to use the PTK Cam software. And the laser is fired using the Schwind Amaris machine. So again, in this as well, we need to make sure that we have a good quality scan. For example, in this, there is no SCC check. Usually, if the keratoconus is very advanced, we may not get the SCC check, but we should always prefer scans where the SCC check or the static cyclotorsion check is there, so that the treatment is aligned to the patient's visual axis. So here we can see if the SCC check is there, then we can select those scans and export them to the Schwind machine. So once we've exported it to the OrCam software, we will get a screen which looks like this. So this is the CW platform, and this is the OW platform, which you can see below. So the first thing that we do is we enter the epithelial thickness here. We can use any ASOCT which is available to do this, either the RTView or the MS39, whichever is available. If it is not available, we can do a manual removal of the epithelium so that we get the entire epithelium. The second step is again the same as it was in the topography smooth or the zero rule that we followed in the wavelight planning. We will enter a zero refraction just to see how the machine is treating the higher order aberrations, even if we don't treat any refraction. So here again, we can see that pattern which we want, flattening at the cone, slight steepening at the just adjacent to the apex, and again an arcuate zone of flattening beyond that. So here we can see that the OW or the wavefront guided treatment is giving us, it's saving more tissue. This is because this is probably because it is ignoring the other aberrations which are coming from the remaining part of the eye, which the CW is not able to do. But again, CW is preferred if you have a highly irregular cornea or a very steep cone. It is also within range. It is still 41. So what you see within the brackets, that is the maximum stromal ablation and the epithelial removed. So for the maximum stromal ablation, maximum epithelium removed, and the central ablation, this is the central stromal ablation as well as the epithelium removed. This gives us the total value. So again, even in the CW, even with zero refraction, we are getting it within the 40 micron zone, which is what we want. The second step here would be to enter the patient's refraction. So in this case, it's around minus 2.5 of a cylinder. And then we go to the manager tab. If I show you the manager tab. So this is where the manager tab is. We can click on that after adding the refraction of the patient. And then we can remove the constraints. So what does constraints mean? Basically, the machine itself has certain constraints. There is internal logs that they have wherein they say that, okay, we are not going to treat this patient beyond a certain refractive error. Once you deselect these constraints, you are basically telling the machine that you are free to treat whatever refraction you want. It does take into consideration the manifest refraction which you have entered. So it will not go beyond that. It will take into consideration what the patient is accepting before giving us a refraction to treat. The second thing that we can do in the manager is a depth minimization. So what this means is basically it calculates the aberrations which are there in the patient's eye. And then once you select depth minimization, it minimizes or it deselects aberrations which don't need to be treated according to the machine. The machine has looked at the topography, it has calculated how much coma, trefoil, SA this patient has, and the machine can deselect the aberrations which don't need to be treated. The machine decides in this case that it is actually the vertical and horizontal coma which is causing a problem. So that is the only thing which needs to be treated. It has automatically switched off trefoil here as well as the spherical aberration. This can vary from CW to OW, from topo guided to the wavefront guided based on what the machine perceives as the important higher order aberration to be treated. There is something called volume minimization as well, that is reserved for hyperopic keratoconus, basically those which are accepting a plus power. It reduces the total volume of tissue. They are not very clear on how this works. The companies have not really revealed how they decide how much volume to be removed, where they remove this volume from. So probably not a good idea to use this in the beginning of starting the TCAT journey. But yes, depth minimization definitely helps to preserve tissue because it is deselecting aberrations which don't need to be treated, thereby saving the amount of tissue to be treated. So again, after we have applied constraints as well as depth minimization, we can see that there is further reduction in the amount of tissue, which we can see in the OW or the wavefront guided treatment. Again, in the corneal wavefront also, it is still not exceeded 45. So at this stage, you can use either of these treatment modules. So if you do not have the OCIRIS T, you only have the CIRIS, which is to say that you can still treat this patient using the CW or the topo guided treatment platform, because you are still within the range of 45 microns. You are not ablating more than 45 microns, and you are still treating almost 70% of the patient cylinder. The patient's acceptance was minus 2.5. You're treating approximately 1.5. So even if you don't have an OCIRIS T, you cannot perform a wavefront guided, you can still go for a topo guided treatment or a CW and treat this patient. The final stage is, of course, to check the manifest refraction, which I just discussed. So in the wavefront guided treatment, you can still add a little bit more refraction if you want. However, that may alter how much tissue is treated. So again, it's on a case-to-case basis. You will keep entering it and seeing how much tissue is ablated and then alter your treatment accordingly. If, however, when you are doing a topo-guided planning on a corneal wavefront or the CW platform, and you find that the ablation, like over here, you can see that the central ablation is 54, maximum ablation is 87. So there is a very high ablation profile here. We cannot go ahead with a CW treatment. So in this case, and we don't even have the wavefront guided treatment. So in this case, we can do a TREC or a topo guided removal of epithelia. This is done on the PTK cam mode of the Schwind. Basically on CIRIS, we can use the tool, the ruler tool, and calculate the long axis as well as the short axis of the cone. When you right click on the CIRIS anterior tangential map, you see a ruler, so you can use that to measure your cone. And you can also measure the offset. Offset is basically how deviated your cone is from the pupil center. And the machine, that is CIRIS, gives you that offset on the corner over here. So you can identify these parameters, enter them in the PTK mode. You can again enter the epithelium if you have access to an A-scan, or you can manually remove the epithelium. Here you will perform a TREC. Basically, it is a PTK, but it is a decentered PTK. In other platforms like Alcon, the PTK mode can only be centered. You cannot decenter it, so you cannot treat a very steep or a decentered cone. However, with the Schwind platform, using the PTK mode, you can do a TREC, and you can see here the cone is decentered, but we are able to move our PTK zone to the periphery. So we do not go beyond 20 microns of stromal ablation here. Again, it also depends on your TCT. It depends on how much epithelium you are removing. And based on that, you can remove approximately 15 to 20 microns. So of course, you may not treat a lot of higher order aberrations here, but you will still end up regularizing the cornea. And this is followed by manual removal of epithelium from around the cone, because obviously you are only treating 6 into 5. So this circle is around 5.56, but you need to do a cross-linking on a larger area. So manually, you will have to remove the epithelium from besides this and then perform an accelerated cross-linking protocol. So just to simplify things, once you have done a detailed evaluation and scanning on the Schwind, Cirrus or Osiris, this is a very basic demarcation that you can do. If your TCT is more than 450, your peripheral ablation is less than 50, central ablation is less than 30 microns, you can go ahead with a TCAT, either on CW or the OW. If you have a TCT which is less than 450, this is with epithelium on, peripheral ablation more than 50 or a central ablation more than 30, you can either plan a trek, or if there is a high ablation on TCAT, then again you can plan a trek. So I could only find one study where they have used Schwind to perform a TCAT along with crosslinking. This is a good study because they also have a control group where only corneal crosslinking was done. They've studied the usual parameters of UCVA, CDVA, as well as the keratometric values, which all showed improvement. In addition, they have also studied the corneal haze, and they've studied the demarcation line of the crosslinking as well. So we'll talk about that a bit later. So this is a 1-year follow-up. They found that the CDVA increased by approximately 2.5 lines in the TCAT with CXL group as compared to the manual CXL group. And corneal higher order aberrations decreased in both groups, but of course, in the TCAT group, the corneal aberrations were more reduced. And again, we can see the parameters which they used. They used a 6 mm optical zone, but they changed that. It could go up till 7 also if they were doing the OW treatment. So they have compared both topo guided treatment as well as the wavefront guided treatment, that is CW and OW. Not in equal numbers, but they have been able to at least take those patients into consideration. And if they had an OW treatment, they treated a higher optical zone because probably they were able to save more tissue, so they could treat more of the refractive error. They did not specify a maximum stromal ablation depth, but yes, they made sure that the RSP was 350 minimum. The epithelium was removed single step in the Schwind itself. So this is another advantage this machine has. If you have the epithelial thickness, you don't need to manually remove it or do a 2-step, first PTK followed by a PRK. In this, you can do a single laser ablation and it will remove the stroma followed by the epithelium in a single sitting. The image acquisition was again on Cirrus and Osiris, and the planning software was Alcon. Excimer used Schwind. Again, in this study, they did not use an MMC, and the cross-linking was done using the accelerated protocol. This is something new that the Schwind machine has come up with. It's called Foresight. Basically, it takes your pre-operative data into consideration, and it gives you an estimated post-operative tangential profile. Along with the post-operative profile, it also gives you an estimated post-operative refractive error. It can tell you how much coma you will correct, how much of the other HOAs you will correct, as well as the total RMS of the higher order aberrations. So one of my colleagues has done a patient. So as you can see, this is the pre-op scan of the patient. And you can see this is the 1-month post-op scan. It is very similar to what the Foresight predicted in terms of the topography. Also, the refraction which the patient achieved at 1 month was also very close to the predicted refraction, which was around 1.36 diopters. So it does give a good idea, but of course, this needs more studies to see if this is actually valid. It is basically using AI, and it's taken into account a lot of patients who have undergone the TCAT on this machine and used it to generate these AI-based profiles. So again, this, I think we can skip this 1 second. Yeah. Okay, so coming to the cross-linking protocols, basically these are the common cross-linking protocols which have been used. Athens used, basically it used an accelerated protocol, but with a 6 milliwatt per centimeter square energy. And the Cretan protocol used the conventional cross-linking. What we usually use is the accelerated protocol with the epithelium off. We want to keep the fluence at 5.4 millijoules. So whatever matches that, either 3 minutes at 30 milliwatts, or say 9 milliwatts with 10 minutes, or 18 milliwatts for 5 minutes. The only consideration when it comes to doing a topo guided correction with cross-linking is that sometimes some authors have said that because we are removing the Bowman's layer, which we are not doing in a manual cross-linking, in a laser-based cross-linking, we are removing the Bowman's layer. So maybe the riboflavin may penetrate deeper and cause damage to the endothelium. So there was a study conducted. This was published in September 2024. And they studied and they found that there was no difference in the depth of demarcation line in either group. That is the group which underwent cross-linking, manual cross-linking alone, as well as the group which underwent a TCAT with cross-linking. This was the study done on the Schwind machine, and they followed up patients for a year and they did not find any difference. So I think it is safe to say that we can do an accelerated cross-linking on patients who undergo TCAT, because most of the parameters which they used are what we commonly used. We use an isoosmolar HPMC with riboflavin 0.1% for a treatment time of 9 minutes. And this is what we usually use. And they have found, at least for a 1-year follow-up, that it has been safe. The second consideration is mitomycin C. There are some studies which say that you should put a mitomycin C because you will expect a lot of haze after a laser-based surgery. Intraoperative mitomycin C can reduce the risk of corneal haze following PRK, and it was used in the original Athens protocol. However, there has been a study which said that topical mitomycin C might actually increase the risk of stromal haze, but the mechanism was not understood. The Cretan protocol again used mitomycin C, and they did not see any stromal haze difference with those patients who underwent cross-linking alone. So it is a personal choice. I have not found anything concrete on whether or not we should or shouldn't use mitomycin C. Coming to complications, the normal complications that come with cross-linking, like delayed epithelium healing, heaped up epithelium, infiltrates, whether inflammatory or infectious, corneal ulcers, corneal haze and scarring, these are common. Particularly for a laser-based cross-linking, there might be a continued long-term flattening or there might be progressive ectasia, in which case re-cross-linking may be done using the Dresden protocol. There are some other machines and protocols which have been introduced to perform a TCAT. I'll just discuss them briefly. This one has been studied by Dr. Rajat Jain et al. It is called the Bharat protocol. They have used data acquired on the OPD scan 3 from NIDEP, and the software used was Final Fit software. This software basically divided your scans into the total ablation, sphere ablation, cylinder ablation, and an irregular ablation. The company has not revealed how it has managed to separate these, but basically what you can see in the irregular ablation profile is that it is similar to what we are trying to achieve in TCAT. This is the treatment profile basically. So you can see that they are ablating the center, they are ablating a arcuate zone in the periphery and creating a slightly adjacent steeper value. So again, they've used the NIDEC CX3 excimer platform. The only disadvantage is that it has a very short follow-up of 6 months. So we'll have to see if they go for a longer follow-up. Again, they did not correct the full refractive error. They targeted a maximum of 1.5 diopter spherical equivalent for correction. So this meets the criteria of what we've been discussing, that you want to do a partial refractive correction. You don't want to exceed 50 microns. Here they've not exceeded 45 microns and they 50 microns, and they did a PTK as the first step for epithelium removal. They've not exceeded 40 microns and done an accelerated cross-linking. Another study which I found, this is again a wavefront guided or an OW treatment equivalent. This was done on the Vizx Star excimer laser platform by Johnson & Johnson. They use data acquired by Pentacam and an iDesign refractive studio. So iDesign is again an aberrometer. Whenever you are doing a wavefront guided treatment, you need an aberrometer because you want to see the aberrations of the entire eye. So if you don't have an aberrometer, you cannot do a wavefront guided treatment. Again, in this, they did an alcohol debridement with an optical zone of 6 mm, followed by a wavefront guided ablation. Maximum ablation was again 40, but they used the Dresden protocol. They again found that the higher order aberrations were reduced on follow-up, and they also noted that there was no clinically significant haze. However, again, wavefront guided treatment of keratoconus is not widely studied. There aren't too many studies. In fact, this is probably the only study which I found apart from the Schwind study where a wavefront guided treatment was done as a TCAT. So just to summarize, we use partial topography guided PRK to normalize the cornea, reduce the irregular astigmatism while treating only a part of the refractive error, not the full refractive error. We plan to treat approximately 70 to 75% of the cylinder and then add sphere later on, making sure that we do not exceed 50 microns of stromal removal. Accelerated cross-linking protocol is safe to be used in conjunction with TCAT, and it should be limited only to mild to moderate keratoconus. That was the end of my talk. I'll take questions now if there are any.
Thank you, Dr. Ritika, for such an insightful and a very detailed presentation. I would like to summarize that this procedure, TPRK, topo-guided PRK with corneal cross-linking, is just to achieve a better contact lens tolerance. It is not a refractive procedure. So the patients must be counseled accordingly. This procedure is going to give you a broader and a flatter cone which tolerates strain better. Has to be done with a minimal corneal thickness of 450 microns, and the maximum ablation that you are planning should not exceed 40 to 50 microns. So accordingly, the optical zone has to be kept smaller than the usual PRK refractive procedures. Same sitting PRK with corneal cross-linking is preferred over a sequential procedure. And another thing that you have to be careful while evaluating the patient. If the patient has allergies, if the patient has any kind of ocular surface disease, dry eyes, patients with autoimmune disorders, connective tissue disorders, these patients, the treatable disorders should be treated before the procedure, and like connective tissue disorders or autoimmune disorders are best left untreated with this kind of procedure. So, Prateek sir, what is your experience or your comments about the topic?
First, excellent presentation, Ritika. You covered this topic in so much detail that you have all the machines, all the protocols, everything you have explained in great detail. I think this lecture being recorded and is available on Facebook and YouTube. I will recommend all our fellows to see this again, because so much things you have put in this lecture that students may need to see this 2 to 3 times to understand.
More than that, sir. More
than that also.
3 times
So at least 3 times to understand what all you have shown.
Yes.
And you have taken this topic in so much great detail. And the advantage of topo-guided ablation, I will say that we were treating patients of keratoconus with CXL since a long time. But for visual rehabilitation, either we had to shift them to contact lenses or to spectacles. So this technique, topo-guided ablation with CXL, this gives us correction in uncorrected visual acuity as well as BCVA also. So for patients who had greater corneal thickness, I will recommend more than 470 or 480 micron to begin with. So they can be treated with this technique. And I have treated one case with our new machine, Schwind. And that patient has gained 3 lines correction in his uncorrected visual acuity. So a patient who was pre-op 636 with BCVA now is 612 uncorrected visual acuity. And once we will do 4 to 6 weeks follow-up, then I think his BCVA would be even better than this. And his other eye, which had BCVA of 6/9, now is uncorrected 6/6 parts. So this is something which made me very pro to this technique, because previously I was very much apprehensive of thinning the already thinned and weak corneal tissue in patients of keratoconus. But now we are seeing that since we can improve the uncorrected visual acuity and BCVA in these patients, and their the dependence on visual aids can be reduced. Because why this procedure was started? Because a patient of PMCD, which was treated by Quinones, he developed contact lens intolerance. And once cross-linking was done and the patient was not able to tolerate contact lenses, they decided to treat it with PRK. And that patient remained stable and got his vision correction and was happy with the correction that was done with PRK after CXL. Later on, they decided that instead of doing sequential surface ablation, we should do it simultaneous because we will not remove the already cross-linked cornea. And then uh, uh, Kanonopoulos and Binder et al. They did lot of work on this and they published their long-term outcome that cornea remains stable even after topo-guided ablation and CXL. And now with the advent of newer software which have got incorporated AI, which calculates the correction to be done, and it gives us foresight software that gives us insight into what will the treated cornea will look after topo-guided ablation and CXL. And we are seeing that it's almost simulates to the post-op scans of the patient. So this things looks interesting and it may be beneficial to patient in long term, and maybe our keratoconus patient for which we were just doing some therapeutic treatment, now we can do some refractive correction and make their life easier. So excellent presentation, Dr. Ritika. And now if there are any questions from the audience, you can take them.
Ritika, are there any
Sir
questions?
and ma'am, there was a question, ma'am and sir. So the question, can I ask the question? Am I audible now?
Yes,
Yes.
yes,
Yeah,
Ritika, we
Yes, sir.
can. Yeah.
I guess the question was ki, how about the TCAT protocol planning in case of decentered ablation or a retained lenticule?
Decentered ablation or a retained lenticule.
Yes,
So
ma'am.
again, for this, it depends on the depth. So if there is a retained lenticule, you have to see the depth at which it is there. Usually it will be there at around 120 because we are keeping a cap depth of 110. So
Yes,
even
ma'am.
in the PTK mode, that will be a slightly safer way to do it. In a PTK mode, you will be able to reach that depth without touching the, because we've already done a refractive correction. In this case, we do not want to remove too much of the stroma. So in this case, a PTK mode or a trek with a slightly higher ablation, which is centered especially over the area of the retained lenticule, would be a safer option if we had to do it. If it is a recent surgery, we will of course try to remove the lenticule manually. If it is an older surgery, then definitely PTK or a trek would be a safer option as compared to a TCAT, because we don't want to remove too much of the stroma. As well as, and as far as decentered cones are concerned, you can do a TCAT even in a decentered cone, provided you are matching the ablation criteria. If, however, it is exceeding the ablation of 40-45, then again you can do a trek for this patient or even a PTK.
So the preliminary data for preliminary thing for planning of TCAT in any case, may it be keratoconus or decentered ablation or any case, remains the same now, ma'am?
Yes, except for the
Okay.
retained lenticule. There you will not even think about a TCAT, I think. You should go
Trek.
directly to a PTK or a trek mode.
Okay. Okay.
Because you've already done a refractive correction by removing the lenticule. You don't want to correct even partial refractive error there.
Okay, ma'am.
So in case of retained lenticule, if there is some residual refractive error, how will you correct that?
So I think the first step should be to regularize.
Okay.
And if at a later date we feel that the retained lenticule portion is not there, the cornea is fairly regular, then maybe we can plan a WFO treatment to correct the refractive error. The first thing should be to regularize the cornea, I feel.
Any other questions, Kritika?
So no, sir, we don't have any questions on online platform as well.
So you can ask few questions to Dr. Ritika.
Sir, I want to know what your take is on the mitomycin controversy. Do you feel we should use it in
So I have not
TCAT
used in my cases, and I think that since we are doing CXL complete procedure, following it for 10 minutes, 9 milliwatt, and we are already reducing the keratocytes in that area. And to suppress the inflammation, we are using topical steroids immediately after surgery. So most of the studies, they have not used it, but some studies have used them. And I think both have published good results. So it's not required, but if somebody wants to use it, then no harm in that also. But one study showed that there was more corneal haze with MMC. I don't know why it showed. And another thing is in that study, after CXL, they used MMC.
Yes, sir.
So normally we do in surface ablation after excimer we use MMC, and then we do cross linking if we are doing PRK extra. But in those cases, I think since we are only partially cross linking the cornea, we are not fully cross linking the cornea. In extra procedures, you are just prophylactically doing CXL. That's only half the energy being delivered. In those cases, you can use MMC, but in this, where you are treating you are cross-linking for a full duration and with full energy, I think it's better not to use that. Because in our cases, few surgeons have used it in our experience, and I have not used, and the results are almost as good as theirs. So why do an additional procedure? And you are not ablating too much. In normal cross-linkings, we are not using CXL. And here you are just ablating less than 50 microns, so not much ablation being done. Yes.
Sir, how about a case of post-LASIK ectasia where corneal thickness is still more than 450, but it's ectatic? So how about planning? Should we go for a TCAT or straight away go for a ICRS implantation with cross-linking?
I have not done, but TCAT in those procedures, I have only done Intex with C3R, and they are giving us quite good results.
Stable results. Okay.
Yes, patients are more stable, and again, I think the post-LASIK ectasias, they are more weaker than the keratoconus patient.
They are unlikely to have a thickness of 450 after
Yes,
undergoing
because
a
we have
myotomy.
already ablated them and we have created a flap, so it's better do just Intex and C3R in those cases, and they do quite well in our experience. Maybe
So
if the patient who develops post-LASIK ectasia and has good corneal thickness, good residual stromal bag, in those cases we can consider if the error is quite high. Refractive error is quite high, then you can partially correct it with Intex and partially you can correct with topo-guided ablation. But our experience is very limited in such cases. We have only treated such patients with Intex with C3R.
So we can even opt for going for a trek in such patients.
Yeah, track you can do because it's just flattening the cone. You are not
Yes, sir.
ablating too much, just 20 micron. You can do that. But I think Intex is sufficient and cross-linking them because you have already corrected the refractive error by excimer laser. In those cases, it is just the biomechanical weakening. And if you diagnose them early, then just Intex with C3R suffice. If it is in advanced stage, then for visual rehabilitation, you may need to do some surface ablation for them if the refractive error is high. What is your take on Dr. Ritika?
Sir, I don't have too much experience of TPRK in post-LASIK ectasia. I have also seen good results with Intex, and they are usually, yes, they are inferior cones, and there is a central flattening over there. So even if you do a trek, chances are you will cause an excessive flattening in the area where there is a myopic ablation. So probably not a good idea for them. But again, I don't have any experience in that.
Intex with C3R, we have done a few cases and they are doing quite well. I have some patients done 6-7 years back also, they are following with me. And Intex with C3R is giving good result. So I don't know whether we will be shifting them to TCAT immediately, but we will see how is our experience goes.
So we have a question, sir, and that is, in a case of formifrostic keratoconus, how should we go about? Like we have treated one eye with TCAT in a keratoconic eye, and the other eye having formifrostic keratoconus. So any protocol particular for the eye with
So
formifrostic
we
keratoconus?
need to see whether the keratoconus is progressing or not first thing. If it is
Yes,
forming
sir.
plastic keratoconus and stable with good vision with glasses or then no need to do anything. Just observe them, advise patient not to rub his eyes, keep the inflammation in check, ocular surface inflammation in check if it is there. These patients sometimes they don't progress at all. So we don't need to do anything for them. Just advise the patient uh, do not rub your eyes and keep for regular checkups. I would advise them to come for repeat scans after 6 months. Mostly these patients, they do not progress.
Okay, sir. Next question is how to decide whether to take a patient for wavefront guided or topo guided ablation.
So first of all would be availability of the machine. Not everyone has a aberrometer to do a wavefront guided treatment. If, however, it is available for you, it again depends on your topography. If it is a very irregular cornea, very steep cornea, you can always plan on both and see which is saving more tissue. But usually, if it is a very irregular, very steep cornea, very decentered cones, then in those cases, a CW would be preferable because you want to treat the topography. However, if it is a central cone and you feel that you will save more tissue and treat more refraction, then go for a wavefront guided treatment. With an irregular cornea, you know that you won't be able to treat too much refraction. Your main aim over there is to regularize the cornea and treat maybe a little bit of the refraction. If you feel that it is a central cone, you can treat more refraction, then go for a wavefront guided treatment. But you can always plan and see where you're saving more tissue. You can play around with the refraction, see if you're treating half the cylinder, which is saving more tissue, and decide accordingly if it's available.
Okay, ma'am.
There is no more question. We can end this session.
Yes, sir. I think we don't have any more questions, sir.
Okay. Thank you, everyone. We had a
Thank you,
nice
sir. Thank you, ma'am.
session
Good night,
on
everybody.
TCAT
Thank you,
and
Thank you,
ma'am.
ma'am.
CXL.
Ritika.
Thank you,
Thank you, sir.
everyone.
Thank you.
Thank you.